Yes. Late onset of hypogonadism in men. And to start with, I would like to start the organizing committee for having given me this opportunity to address you. Also, I'd like to congratulate 14th of March, which is set as the medical day. And lately, the patient's rights have been dominant lately. And unfortunately, this had a negative reflection on the relationship between the doctor and patient. Today, in this presentation, I'd like to give you some information on the late onset of hypogonadism in males. Actually, late onset hypogonadism is there is an epidemiological dimension. For example, way back in the 1920s, someone that was born then was sharing the globe with 1,860,000,000 others. Today, someone that is born today is sharing the world, the earth, with 6 billion individuals. And it's such a share that the aged portion of this population has increased threefold. And so as a doctors, we have to dwell on the problems of the elderly. And we also have the task of managing late onset hypogonadism. Why does the population age? What lies in the background? There are lots of issues that need to be considered. Family planning, contraception, and certain behavioral changes. Preference of remaining single or late marriages or planning and having lesser number of children. These types of changes has given rise to the further increase of the aged population. Another aspect is people are living longer. Health services have improved. The screening tests are employed for some diseases, and the expected survival as compared to the past has increased tremendously. As a result, this has increased the numbers of the aged population. If we are to define the elderly or aging, genetic factors, also nutrition, lifestyle, so that when these develop, it's a case of breakdown of these. What is aging? When we review literature, those over the age of 65 are called aged, and those that ever over the age of 85 are called very old. Actually, sexuality in the elderly, when that is the subject, different intellectual environments have a different interpretation. And especially sexuality for the elderly is immoral and unfit. And some people define it as such. Others believe that it's a physiological behavior and that we should work to overcome this problem. So there are groups of people that have two different outlooks, but regardless of what our outlook is, sexuality is an integral part of our lives. It could be considered as a part of a social problem as well. As people age, they start losing some of their functions, and especially in one of Shiley's studies, around the age of 90, that sexual desire is reduced, highly reduced and lost. But only 15% have a sexual activity that's still continuing. As people age, sexual life does get the detrimental effect. For example, Kaiser has a study. The frequency of sexual intercourse is questioned. Between the age of 46 to 50, 95 of them at least have once a week sexual intercourse. Between the age of 66 to 71, only 28% have intercourse once a week. And in sexual life, the reduction or decrease of rhythm is based on certain mechanisms, hormonal, neural, or certain vascular mechanisms can be the cause. And special serum testosterone levels are directly influencing libido, which is reduced in the aging male. And also physical stimulants. Usually the erection response does not change in the genital area, but visual and psychological and non-genital stimulus does not give rise to erection in the elderly, or is highly reduced. In the aging population, feeling of liberation is reduced. Neurotransmitter pathways are reduced as well. And especially vascular mechanisms in the intercavernous area where it is intensive, the smooth muscle content of the corpus cavernosum is reduced. This mechanism naturally decreases sexuality in the elderly or as men age. In males, sexual life and male feelings, emotions and phenotype is based on testosterone. We have to know testosterone. 95% is in the Leydig cells, about 500 to 700 million Leydig cells which synthesize testosterone. About 5 to 6 milligram testosterone is produced daily in the body. And the source is cholesterol, which every one of us call the bad cholesterol, the extracellular media, and the LDL cholesterol. The LDL cholesterol is carried to the mitochondria, where the cytochrome 450 enzyme group changes that into pregnenolone, and the utilizing hormone LH is coming out. Pregnenolone that is sensitized is carried to the endoplasmic reticulum, where with a sequence of enzymes, testosterone is synthesized. From prednisolone to testosterone, this change actually is directly in ratio with the enzyme. Testosterone production potential of the individual, or the only limiting factor is the amount of enzyme. And prednisolone, whole of it can be transformed into testosterone. Testosterone that is produced is enters the circulating system with pumpiniform plexus. The circulating testosterone, 98%, unfortunately is bound to protein. Only 2% is free testosterone. And we know biologically the active function of the testosterone dictates that it should be free or should have a weak contact with the protein that it is bound to. Free testosterone and albumin-bound part can survive. The sex hormone binding globulin and testosterone relationship, unfortunately, is very close, but it is biologically inactive. The testosterone that enters the cell, together with the aromatoses, it's turned into estradiol, or with 5-alpha reductase, it is turned into more active testosterone. 1,000 liters of blood are cleared of testosterone daily. So 67 milligrams of production per day. Its half-life duration is 10 to 20 minutes. Serum levels is 610 nanograms per deciliter. It is stabilized around this level. And this picture that is seen in the male, this change, chemical and biological, are expressed with certain concepts and definitions. In literature, we will observe different versions. The male climacterium, the andropause definition, for example, in reality, has been inspired and adapted from the menopause in the female. It does not reflect reality. In the female, the reproductive cycle is terminated with the menopause. When it is adapted to the male, that is not exactly the same case. In testosterone, the change in the testes is only with reduction of testosterone, but the reproductive capacity is not terminated. So, starting off from that point, for example, certain definitions have been brought about. In the elderly male, a reduction of androgen or partial reduction, the best definition should be later onset of hypogonadism. Later onset hypogonadism is one of the sine qua non. And accompanying age, the serum androgen levels are reduced, and it is a clinical picture. When these two are together, then we can use later onset hypogonadism. To a certain extent, this does bring about changes in the quality of life or give rise to changes in various organs. What are the clinical findings of hypogonadism that is late? First of all, erection quality and sexual desire is reduced, and also intellectual activity is reduced, muscle mass is reduced, body hair is reduced, visceral fats increase, skin quality changes. When we look after the age of 50 in the total testosterone serum, there is a reduction at the ratio of 4:1. The biochemical hypogonadism in this picture, below the age of 60, it's around 7%. Over the age of 60, it reaches around 20%, where biochemical hypogonadism is established. And sex hormones for many years increase. And on behalf of testosterone, this is an unlucky trend. The biologically active testosterone cannot be computed easily. Serum total testosterone level, globulin and albumin levels are set, and there are practical automatic computations of this. Biochemical hypogonadism in the elderly, the lowest levels cannot be easily set. But total testosterone, 320 nanograms, it is below 320 nanograms. Free testosterone over 6.5 nanograms per deciliter. Biologically active testosterone levels, if it is below 10 nanogram per deciliter, we can define it in this manner. Especially testosterone in the serum has a circadian rhythm, and especially in the morning hours, that is the highest level, during evening, it lowers, and after night towards morning, it is increased again. So, for testosterone level determination, we need to standardize the blood sample to be taken in the morning. If the serum total testosterone levels are low, the biologically active testosterone or free testosterone should be computed. LH and prolactin levels should be considered as well. Circadian rhythm in the process of aging is losing its trend in the young. The circadian rhythm can be lost in the elderly, and 24 hours of the day, similar and lower testosterone levels are seen. What is the objective of treatment? To replace sexual function, make him gain back his libido, and also to make him feel well and healthy. What can be done is androgen replacement therapy. For androgen replacement therapy, biochemical hypogonadism must exist in order to start that therapy. In the existence of biochemical hypogonadism, clinically, the symptomatic patients can have androgen replacement therapy take place. For androgen replacement therapy, age is not a limiting factor. And certain products exist for that purpose. As the previous speakers have pointed out, if I'm to summarize, injectable products, especially, besides being a low cost, and at the supraphysiologic levels, it does have a certain risk. Androgen replacement therapy in a patient, in a case where the TSH increases suddenly, and high testosterone level, and a long-term product had been administered, it is difficult to revert it back. There are oral products. The biggest difficulty here, as you know, is that the first pass damage in the liver, and especially when it enters the portal system, the liver can be damaged. And amongst these, testosterone antigonad with can bypass the liver and sort of serves our purpose more. And subcutaneous products, the long-acting types that have been developed lately, when we want to terminate the treatment, that is risky. But the transdermal products, perhaps, from this perspective, are the most dependable ones. The only problem on the scrotal skin, it can give rise to certain allergic reactions. The scrotal skin, as far as PDE5, is pretty rich, and the products that are employed here, and their testosterone return will be at a high level. And also these drugs do have certain important side effects as well. And since these are types that have to be used for life, they need to be followed closely, and especially follow up in patients should be able to fit the purpose. For example, a patient with osteoporosis, the bone, mineral density should be considered, and if there is a sexual dysfunction, there should be questionnaires that should be used in the follow-up, especially in cases of prostate cancer. In patients that have testosterone replacement, should be considered with great care. It's a serious problem. TSH values and rectal examination with the finger, if it is normal, then the patient can have androgen replacement therapy. But if in a patient, if the replacement therapy is started, during the first 2 years, these 2 examinations should be repeated every 3 months for 2 years. If there are no abnormalities, then this can be repeated annually. Breast cancer is another contraindication. Breast cancer in the male also. And also, benign prostate hypertrophies are a contraindication and also can cause acute urinary retention. On sleep apnea, we can't say that is anything evidence-based, but it's another situation that we have to be careful about. Distinguished colleagues, late onset hypogonadism, and we laid forth the testosterone. But it's not only testosterone that's responsible. Growth hormone, melatonin, thyroxine, and several other issues like this hormones that need to be followed up. But I believe this will consist the subject of another presentation. I would like to thank you for your patience.